This is a talk about a pretty specific injury. So for the folks here that haven't seen a lot of these injuries, nor anticipate seeing a lot of these, I apologize. It's a relatively technical talk just because this is a very specific fracture pattern. The important thing is not to miss these injuries, though. I thought I'd just start out with the case, just as a point of introduction. And this was a young guy who was sent in about 6 weeks after open reduction internal fixation of a perceived articular injury of the distal femur. And I think as you look at this, you see some of the issues associated with this. You know, he only has about 40 degrees of motion, and he has a real hard block to further flexion associated with this. And I think this really represents a relative misdiagnosis in terms of the injury. Because you can see on the medial side, there was certainly a lot of attention placed on the medial side, but I think you can see on the lateral the articular injuries posteriorly associated with this. And that's just really an introduction to what Hoffa fractures are. And this took a pretty extensive reconstruction. I had to do a subsequent osteotomy to unload his medial joint space. I wish Jim Stannard were around, because I think this guy truly did need some type of an osteochondral replacement of his distal femur ultimately. So I'll try and talk about some of the different injury patterns that we see for these coronal plane fractures of the distal femur, as well how they relate to routine supracondylar, intercondylar distal femoral fractures. More importantly, for the orthopedic surgeons in the room, we'll talk about surgical approaches for these so that you can successfully treat them, as well as what we kind of know about different fixation strategies for these specific injuries. When I think about distal femur fractures, there are a variety of different factors that contribute to the overall complexity of these injuries, but what I'm going to talk about are really just these coronal plane fractures that we see, either in isolation or associated with other injuries about the knee. And this complicates both the surgical treatment as well as ultimately the rehab for these. This was the original article, because there's a name attached to these. This was actually named after a radiologist. And it truly is for the description of an isolated coronal plane fracture of the distal femur. Now, in reality, we see these more often associated with other injuries at the knee, and they rarely are actually in isolation, and I'll talk about both of those injury patterns. This was really the first large series, though. This was over 20 years ago. It really doesn't give us great insight, but at least someone went through and cataloged. Believe it or not, 20 cases is actually a pretty big number for these, because they're not that common. However, we kind of found at our institution too, that if you really start looking for these, the number tends to rise, especially if you really carefully scrutinize CT scans for these injuries. So, coronal plane fractures. As you can see in this film, it's very easy to see when you have this much displacement of the anterior half of the joint, and here's the posterior portion of the femoral condyle. But if you look at other fracture patterns, it starts to become more subtle. But if you really start staring at the lateral view, you can certainly see the articular step-off in that location. And it can also appreciate that's right in the weight-bearing portion of the distal femur, especially in extension. And this is the CT scan that corresponds to that injury. Now, sometimes they're even more subtle. I could stare at that lateral view all day, but I just don't see the coronal plane fracture, and it's not until you see the CT scan that you realize it exists. It's important to know, A, that it exists so that it can be addressed, but also whether or not it's the medial or the lateral condyle so the surgical approach can be adjusted. We worked with some of our radiologists, and this was several years ago, where he did notice this association with high-energy supracondylar, intercondylar distal femoral fractures, that these would show up. And this really got us looking into these in more detail. And then several of us went through and looked at over 200 supracondylar, intercondylar distal femoral fractures. These were mainly blunt trauma patients at Harborview that tend to be relatively high-energy injuries associated with these patients. I actually found that 38% of patients would have a coronal plane fracture associated with a supracondylar, intercondylar distal femoral fracture. Luckily, about 3/4 of these were located laterally, just because that's the more typical surgical approach that we use to treat the supracondylar portion of the fracture. I think more interestingly, though, when we started to go back after we had established a number of these patients that had these injuries, maybe about 3/4 of these you could see on the lateral radiograph. CT scan added about 15% more. But at this point, we weren't routinely obtaining CT scans on all distal femur fractures, and these were intraoperative discoveries that still weren't visible on any of the plain film radiographs in about 13% of patients. And so I think it's become routine now that a CT scan is obtained with every distal femoral fracture, but this would certainly suggest that they're necessary to look for these injuries. This is kind of a classic Harborview patient. This woman was in a motor vehicle crash. She had an open distal femoral fracture, and you can see the amount of bone loss associated with that injury. So this is an extremely high energy open injury. As an aside, this woman was thought to have a skull fracture just because she had crepitance about her forehead as well as an open bleeding wound. As it turns out, it was actually part of her femur that had gone under the skin of her forehead that had produced the open injury, and she didn't actually have a primary skull fracture. I remember her well. Yeah, classic. So this is what her sagittal reconstructions on the CT scan demonstrate, which is a really classic pattern. Now, if you really want to get down to specifics, it's not truly a Hoffa. This is just a coronal plane fracture associated with a distal femoral injury. Because specifically, a Hoffa fracture really does refer to the isolated injury, but these are the ones that we treat so much more frequently. So it's important that we do address these. In this case, it did involve the lateral femoral condyle, large interdigitating fracture surfaces that could be stabilized with 3.5 millimeter screws and then go on to reconstruct the joint and eventually plate this. Had to use antibiotic beads for the defect, and then several procedures later got the supracondylar component to heal. But what we're most concerned about today is the coronal plane fracture of the distal femur. There are a lot of other associated injuries with these, and we even found in femoral shaft fractures and even tri-level fractures of the femur, femoral necks, femoral shafts, and distal femur fractures, we would see these. So even in those associated injuries, we want to carefully scrutinize the knee joint and potentially even get a CT scan in that location. So we kind of found that direct lateral approaches are really not optimal for visualizing these injuries. Kind of find that you need a significant amount of knee flexion in order to be able to see the fracture exit point and to accurately reduce the joint. And so if they're on the lateral side, can probably better visualize these through a lateral parapatellar approach than through a direct lateral approach, which I think all orthopedic surgeons are very familiar with, the direct lateral approach for application of a plate on the lateral portion of the femur. And you can fix and stabilize a large lateral coronal plane fracture through that, but it's certainly get much better exposure with a lateral parapatellar approach. Now, about a quarter of these are on the medial side, and I think these are the ones that are incredibly difficult to take care of only because of unfamiliarity with a medial-based approach for these articular injuries. And a medial parapatellar approach or a medial subvastus approach through an anterior or a medial-based incision will allow access. This is the lateral femoral condyle. This is the medial femoral condyle. It will allow access to the vast, vast majority of the medial femoral condyle to fix these injuries. So once we've got them exposed and clamped, now how to fix them. So we really do have obvious choices in fractures that are in this plane. We like to put in lag screws to compress these fractures, and whether we do these from anterior to posterior or posterior to anterior is one potential decision point. Now, just from a practical standpoint, though, this is not readily anatomically accessible to be able to place screws reliably perpendicular to the fracture from posterior to anterior. So in reality, we're fixing most of these from anterior to posterior, and typically with smaller screws than I think what we traditionally used. This is often placed through the patellofemoral joint, so through the cartilaginous surface of the distal femur at the trochlea, just in order to get the right orientation of those screws parallel to the fracture. So it does involve countersinking the screws. And there's also still the question of how many screws are necessary. And I don't know that it's completely answered, but I'll at least give you our experience with taking care of these. This is what you see when you try to look up the biomechanical studies that make recommendations for these. And I just lifted this out of these, only because you can just see, believe it or not, this is the biomechanical study that was used to justify that posterior to anterior fixation was better than anterior to posterior fixation. But there is no anatomical way that I know of that anyone can place screws in that particular location at the distal femur. Now, Dave Hack and others tried to look at what size screws would be necessary. Now, I think it's probably expected that, sure enough, 2 screws are stronger than 1, and larger screws are stronger than smaller screws. Obvious, we see that everywhere in orthopedics. The problem is we don't know what the optimal fixation strength that's necessary to prevent these from displacement. So I think we have to rely on experience more than some of the biomechanical studies that you may be familiar with. So we've fixed literally hundreds of these over the years at this institution using 3.5 millimeter screws, but definitely having 2 points of fixation in place strategically to allow these screws to compress the fracture. And the reason that we do tend to use or try to use smaller implants, even though we know larger implants are biomechanically stronger, is we typically have to leave some available real estate for other forms of fracture fixation to fix the associated injuries at the distal femur. And so that's why we've typically gone to 2 countersunk 3.5 millimeter screws placed from anterior to posterior for simple fracture patterns. And then as the complexity increases, so will the implants. And this is just an example from one of my partners. This is from Dave Barre, just showing a more complicated injury, but predominantly relying on anterior to posterior fixation for these, as well as fixation out of plane to improve the overall strength for that. We looked at these because we struggled for a number of years on these medial Hoffa fractures. We were struggling to do these in extension and with a direct medial approach. And Darius Viscontis, one of our fellows, had written up just a little review, but really to introduce kind of a better fixation technique, I think, for the fixation of these, just to allow for improved exposure and fixation for medial-sided injuries. And this was just from Darius's manuscript, just demonstrating, I think for arthroplasty surgeons, this is an extremely familiar approach. It just unfortunately rarely gets applied in trauma, but it should be because it gives ideal exposure for these medial-sided injuries. But it's a little bit counterintuitive for the approach that people would reflexively select to treat these. And here's just an example from several years ago. Young female involved in a motor vehicle crash with a medial-sided fracture, and you can certainly see the extension of the coronal plane fracture isolated on the medial side. The CT scan, it shows the very characteristic arrangement and fracture plane. And then the fixation for this. This was an open injury, so we had some improved access, so we had a combination of both anterior to posterior screws as well as smaller posterior to anterior screws countersunk to reconstruct the articular surface. And then just because she additionally had some extension into the medial condyle as well as the coronal plane fracture, fixed it with an additional small medial plate. I think just one case to end on, and this is another case actually of partner Dave who took care of this patient that was referred in a delayed fashion. And so this elderly female who had sustained a relatively low energy injury, unfortunately the diagnosis wasn't made, and this was her at several months after her original injury. And I think all can appreciate, now that we've been looking at these for a while, the fracture line on the lateral view of that coronal plane fracture, you can see the valgus deformity of the distal femur. Here's the CT scan demonstrating this, and this is in a patient with relatively poor bone quality. And so I think someone at several months, one may consider just giving up on this joint, just given the amount of displacement and involving the weight-bearing surface of this. This was her 3D CT reconstructions that you can see really separating off the posterior half of the medial femoral condyle, her long leg standing films demonstrating the valgus deformity associated with this. This is what Dr. Barre did intraoperatively. You can see the large defect left behind once this was put back into the proper position. Calcium phosphate was used to fill that large defect, and then multiple planes of fixation to ultimately stabilize that particular injury. So this is her immediately post-operatively, and it did retain its articular reduction for 4 months, and then most recently at 8 months, which I think is a really nice save for a patient's knee joint, as opposed to going to arthroplasty options or any type of an allograft replacement. So just to summarize, really the most important thing on these is to recognize their existence, know their association with supracondylar and intercondylar fractures, and look for them with CT scans, with sagittal reconstructions to identify these injuries. Once identified, it's important to know multiple surgical approaches to be able to treat these injuries, because they are complicated and they're not in a particularly convenient location from a surgical standpoint. And because it does involve the weight-bearing portion of the distal femur, it's very important to anatomically reconstruct these. Thanks very much.
The topic is nailing of metaphyseal fractures, and actually I would like to focus on the fact that it's usually not the implant which makes us the problems. A couple of disclaimers. There's no conflict of interest for a couple of paid editorial jobs, and the learning objectives are that we would like to understand the problems related to the nailing of metaphyseal fractures in the lower extremity. I'd like to demonstrate some of the options to solve fixation problems, to learn about the principles of starting point planning, which is absolutely crucial for the successful fixation of these fractures with iron nails. Learn about polar screws, principal planning, size and placement, and realize the threats to stability and in alignment which might come up along the treatment way. And again, I have collected a couple of examples where I would like to show it's not the implant, it's not the nail which is the problem. Intelligent implants, we all would like to have more intelligent implants. We don't have them yet, so maybe more intelligent application of currently available implants is a solution, and the intelligent solution usually is not using more metal to get better stability and a better outcome. What are the problems? Instability and malalignment is predominant in proximal tibia fracture, and this is shown with by a variety of authors, and very much much higher the problems in the proximal tibia when compared to the midshaft and distal tibia fracture, because we have a very special anatomical and mechanical situation in the proximal tibia. Let's have a look at this example. It doesn't look like a very complicated fracture, but it ended up with an amputation, and the treatment course was like this. It had a nailing, and we all see the starting point too far low and not at the right spot, and there was instability and malalignment, so traction was needed. So it's not a good sign for a post-operative film, and it ended up with infection, subsequent revisions, and finally amputation. Approach is absolutely crucial for this, and nowadays we have some more options: suprapatellar, parapatellar, transligamentous approach, and I think it's worth to follow these new approach options, but we, at least from our point of view, need more data, especially on the side effects of cartilage and the rest of the joint fractures until we can recommend it in a more general way. The approach is crucial, and I have never understood why for an implant of, let's say, 8 or 9 millimeter diameter, we need an 8 or 9 centimeter approach. And we all know these patients, they complain not about the midshaft fracture when the fracture is healed. They do not complain and point to the middle of the tibia. There's a plane. They point to the starting point. They complain about the inability to kneel. And we think if we do careful planning, we can really focus on some more tissue, soft tissue. Better soft tissue handling, and we can end up, if the starting point is nicely planned and nicely selected, we can end up with a starting point which is looking like this. And the prerequisite for this in our hands is that we have a very steep approach, which actually starts not at the proximal tibia. The soft tissue axis starts at the distal third of the tibia, because we have, as a longitudinal axis, we have to insert the proximal tibia very steep in order to get aligned into the medullary cavity. And the medullary cavity, the orientation of the medullary cavity is absolutely crucial. That's for the lateral view. For the AP view, is always a little bit misunderstanding as well, because what you palpate is the anterior tibial crest, but the anterior tibial crest is not the center of the medullary cavity. The center of the medullary cavity is always a little bit more medial. So if you palpate and think this is the middle, you are wrong. It's always a little bit more shifted to the lateral, to the medial segment, and this needs to be considered. And if you are unsure, play a C-arm shot and marking with a short K-bar is a good temporary help. We also position, we do not use a fracture table, we use a simple frame from the external fixator set with 4 tube-to-tube clamps, and we hang the tibia, the knee, onto this frame, so gravity makes some sort of a cross reduction. And especially in open fractures, it gives you full access, and you can fully bend your broken leg in order to brush out, to wash out, to clean out the debris and the dirt of the street. This is probably helpful especially in open fracture situation. This is a very, very old, but nonetheless a good study, because it analyzed the anatomy of the proximal tibia. The proximal tibia is not a symmetric organ, it's asymmetric, and we know all these asymmetric prostheses which have this offset in order to hit the medullary cavity. So the study did some retrograde reaming, and in 75% of the cases they ended up lateral of the lateral spine of the tibia, in 25% between the medial and the lateral. In 0%, they ended in the medial to the medial spike. So the message from this paper is stay lateral more than you think, because the proximal tibia is a very asymmetric bone. The other problem in the proximal tibia is that the muscles are also asymmetric. All the muscles are on the lateral side. So this is causing a momentum. Eccentric forces also favoring the valgus deformity in almost all cases of the proximal tibia fractures. And the starting point is therefore needs to address this, be very, very steep, and it's easy to move the guide wire from anterior to posterior, because posterior it's empty, but once you are posterior, it's very difficult with your nail to compress this dense bone in this tibial triangle. So it's easy to move, to correct from anterior to posterior, but it's very difficult to correct from posterior to anterior. It's always advisable you start very, very steep and correct to posterior rather than anterior. And again, the soft tissue starting point is in the distal third of the patella and not lower. There are a couple of instruments which make our life easier: distractor, external fixator, collinear clamps, chain screws with T-handles, which can be easily used intraoperatively in order to get reduction or temporary fixation, and also additional implants help us to get better alignment and to improve stability. And the concept is that we share the tasks. For example, if you have short reduction plates, we share the task. The plate does address the translation and the rotation, and the nail maintains length and bending, neutralizes bending forces. Other options, this is a little bit out of date, but pinless external fixator. You look how nicely this corrected this malalignment and instability. Again, the pinless has one group of tasks: translation and rotation, and the nail did the rest. So this is the principle of implant sharing. Another group of implants which help us to address malalignment and instability are polar screws. And this is a case from clinical routine, and we saw this picture in the morning conference. Relatively simple fracture pattern, and we realized the misfit in the diameter between the inner cortical bone and the outer surface of the nail. So there is some misfit, and this causes instability, malalignment, and pain, and the postoperative films were like that. So we decided we revise the case early on, and what we did was very, very simple. We temporarily removed the nail and made sure the nail would not fall back again in the old nail path, which would have happened if we would not block this nail path with the blocking screw. And now, simple implant, but everything is now very easy. Reinsert the nail, and what's happening when the nail enters the distal main fragment, it shifts the nail, the distal main fragment to the medial side, and the alignment is much better than before. Then you do distal locking and back slap and realign and adapt the main fracture line. So this is the postoperative situation after 12 months. Good alignment, reasonably good fracture healing, and this all done with a simple screw for $10 and a simple additional access, but on the right spot, and you need to reflect the correct pathoanatomic situation. This is the situation before, and the little polar screw has done this effect. Well, what are the problems in this metaphyseal tibia fracture? And we made this little plexiglass model with a UTN, 3 locking balls. We have oblique fracture model, and we have oblique fracture. When we load the fracture, of course, we have this dislocation and we have this shift. But despite the fact we have 3 distal locking belts, we have, for example, in osteoporotic bone, significant instability still remaining because we have nail translation along the interlocking screws. And we can address this, we can solve these problems when we understand the process. We have this oblique fracture sign, now we axially loaded, and what happens, the fracture shifts, we have shear, and we have limited contact. We reduce our contact to normal down to 18%. And when we prevent this by putting in polar screws on the blunt side of the angulation, always on the blunt side. When we now axially load it, what is happening? We compress instead of produce shear forces. Compression is good for fracture healing. And in addition, we have full contact area of 100%. And if you start this video here on the top, we can see here are the polar screws, and when we now axially load it, maybe you can start the video here, then where there is no shift anymore, there is no shear anymore, there's pure compression once we address this with vertical load. Polar screws therefore can reduce diameter discrepancy, they prevent translation along the screws, they increase the contact areas, it transforms a bad shear into the good compression, and we have proven this in biomechanical experiments as well as in clinical papers. We can correct and maintain alignment, we increase the primary stability pretty significant, and we enhance the nailability. But we pay a little price, we have additional radiation, we have potential nail damage, and we need good knowledge of the pathobiomechanics of the specific situation. Here an example, proximal tibia fracture doesn't look complicated, doesn't look difficult. It invites for intramedullary nailing. Let's have a look how it ended up. Starting point, a little bit low. What's about alignment? It's not perfect, so maybe it's getting better. And we have a look what's happening after 3 weeks. We have this situation with more valgus deformities. It's after 6 weeks, it has even increased, and the patient has pain and has limited mobility. He cannot fully weight bear. So we decided for revision. That's her clinical setup before the operation. Pain after 6 weeks, still on crutches. So pre-op planning is essential. We need to make sure the nail doesn't go too far posterior, and even more important, it's to choose the proximal starting point. This is good bone, hard bone, and we need every millimeter in the short proximal fragment. And we can also see how it went post-operatively. We have this analysis, and for the frontal plane alignment, again, we need every millimeter in the proximal fragment. We need no medial, we need a lateral starting point, straighten out the situation, and we need to prevent the nail from moving to the lateral side, keep it along. This is the polar screw, and this is the effect. And in proximal, we did a K-bar in order to prevent the nail from shifting to his old nail bed, which was much more lateral. So this is the post-operative situation here. Immediately post-operatively after 10 weeks, good and sound callus formation, and further on, uneventful treatment course. Industry has us provided with some more expensive screw systems. Let's have a look how this works. Angular, maybe you can start the video. It's starting angular stable locking, but when we watch this case of a relatively simple distal tibia fracture, we see over the treatment course the screw could not prevent from getting into valgus deformity. So maybe other forms of stabilization would have been more advisable. So other tricks and other situations we might use in proximal tibia fractures, we can take advantage of the asymmetric profile of the nail by using polar screw. We have here this deformity, but by rotating the nail, we can get a better alignment, and just by using simple implants. We can use the same effect by rotating the implant using the shaved curve. If we have more diaphyseal fracture situation, just by rotating, we can address small amounts of frontal plane deformity. And here more in detail, we see that just rotation of the nail changes the frontal plane alignment. So just make sure the locking bolts are out of the patient before you rotate the system. Next, let's the metaphyseal fractures also are applicable on the proximal, on the femoral side, and I would like to share with you this case of a 36-year-old lady. She had this fracture. During the fracture of nailing insertion, it came to another fracture more proximal, but we were not perfectly happy with the result. She had some mild varus deformity. We let the nail in place, but after 1 year she developed medial knee pain, and we brought her to operating theater, did arthroscopy, debrided her meniscus, but at the same time we revised her for her femoral shaft fracture, tried to correct the alignment, and it's not the nail which is to blame, it's maybe some attention to details intraoperatively. Here's the situation. We have removed the nail. We have put in a polar screw in order to correct and drive the nail in our desired way. And look, when now the nail enters the proximal main fragment, look how the entire construct gets aligned and gets incredibly stable just by entering the main proximal fragment with the in the planned way, which is defined by the polar screw, which is given by the polar screw. Very simple implant, but placed on a strategic location, then it has this good effect. And then after removal of the proximal shunt screw handle, reinsertion of the screw, and proximal locking here, the follow-up situation which shows a good alignment after a correction, and on a long term also good fracture healing and good alignment on a long run. Also, polar screws can block wrong nail passes due to wrong entry points in the proximal femur. We know the situation. Once we have a wrong starting point, there is a high risk that the nail slips back into the old nail path. This can be easily prevented in both planes with polar screws, and the anti-curvation tendency also can be blocked with this placement of these screws. Here, an example of a young patient skiing accident, first hospital built-in rotational deformities. Then she entered a second hospital which corrected her internal rotational deformity to an external rotational deformity, but the varus deformity stayed. So she came to us as a third hospital, so we tried to address this deformity, took out the nail, and it's not the nail problem, it's the access and starting point problem, did some preoperative planning, and then the new nail always would have the tendency to fall back into the old nail bed, so we blocked it temporarily during the operation. Here you see the old nail path with the neck screw. There is postoperative a good stabilization, so it does not need additional permanent blocking screws. And here a final case, also malalignment in the distal femur. It's not the nail, which is the problem. It's maybe the understanding of the surgeon. The patient is unable to walk without crutches, so he has instability because his cruciate ligaments in the flexed position of the distal main fragment are never tensioned, and this causes instability. It causes pseudo-laxity, and this needs to be addressed not by ligament replacement. This needs to be addressed by corrective osteotomy, and this needs to be carefully planned with making sure that the new nail position gets in the perfect canal. The wrong nail canal needs to be blocked with polar screws, and then we can insert the old nail in the new position and can use it as a lever arm, and then correct the alignment. Here, intraoperative situation, a short shear arm shot, and here's the postoperative situation. We see the alignment controlled on the posterior cortex is pretty nicely, and we have a very sound and uneventful further fracture healing, just addressed by two simple screws, stable, no nailing of metaphyseal fractures is a little bit tricky. We need to understand the pathomechanics, and we have a variety of things which are especially to consider. We need to apply these principles to fixation, analyze the problems early. Positioning and starting point are absolutely crucial, and there are a variety of additional tools which could help us, plate and puller screws, and again, it's not the implant which is the problem in these cases. Thank you very much for your attention.
I'm going to talk about bicondylar fractures of the tibial plateau, moving just up a little bit from the metaphyseal region into the joint itself. So what's the problem? Okay, well, in this particular case, it's bicondylar tibial plateau fractures, which can be quite commonly and challenging and are associated with high degrees of soft tissue injuries. We have a lot of challenges that we try to meet when we're taking care of these, and even more ways that we can go wrong. So what's important? Well, certainly avoiding soft tissue complications, right? First, do no harm, right? Primum non nocere. But restoring and maintaining our alignment, just as we learned in the last lecture, can ward off poor functional outcomes. We know from a while ago that varus is extremely poorly tolerated, but because we're trying to avoid soft tissue injuries, there was a tendency towards undertreatment on the medial side, and probably an underappreciation of what a bad actor the medial component of these fractures are. So not so long ago, really only in the 1990s, before we had locked implants, we used conventional screws and plate systems typically for these fractures, and they often went into varus. We learned from Dan Horowitz that a double plate construct in a biomechanical study was substantially more solid, not surprising, right? So the problem with this was that if you did this through the used anterior approach, the infection rates were up to the high 30%. And that's just unacceptable, right? So we went into an era of almost surgical nihilism, okay, moving towards external fixation. You can see on the left, it's been fixed with a plate and screw system, but neutralized with a 2-pin frame that was left on for 4 to 6 weeks and then removed. Others used ring fixators, okay, with limited internal or no fixation of the joint. Or on the right, the hybrid fixator that was more like a standard external fixator distally, but like the ring fixator north. But then we realized there are other applications for external fixators, and extrapolating from what we learned about the tibial pilon, where we delayed fixation and brought things out to length, we learned to do a temporizing external fixator, spanning the knee, riding out the storm of inflammation, swelling, and injury, and allowing excoriated tissues to reepithelialize, and then coming back after a thorough preoperative planning and doing this in the light of day and perhaps having a better chance of getting a good outcome. Because the soft tissue injuries often evolve. They're dynamic, unlike the skeletal injury, which is easily assessed on our imaging studies. This often evolves over the first few days. So along comes our new technology, the locked plating systems around the turn of the millennium. And these, it was hoped that would help us maintain our proper alignment while eliminating that second or the increased exposure required to maintain the proper alignment. We started to have reports on this. In fact, Jim Stannard's here. This is his study. 39 injuries, 10 of them were open, and very good results at the articular. Less than an average of a millimeter step off, only one malalignment in each the sagittal and coronal plane, and only 2 superficial, in fact, pretty good results. There were biomechanical studies as well. Mueller had this as well, and Gossing, which I believe is from your group, Dr. Krettek, right? It was a cadaver model. Again, the LIS, or less invasive stabilization system, versus dual plating, a lateral plate and a posterior medial plate as well, so 2 plates. Well, this is a rather large medial fragment. It's vertical, as we typically see, but it's a relatively large fragment. So now here we are at the stage 1 of our new technology research. This locked lateral implant, no worse than doing the 2, doing about the same, is a potential solution to our problems of the added exposure for these difficult fractures. One of the issues was that on the medial component of these bicondylar fragments, it hadn't really been as sorted out early on. The original Schatzker classification, they didn't sort out a fracture that had the entire medial condyle on it or simply a posterior medial component. And in fact, they're quite different. And even some of the textbooks until recently showed the displacement of the medial fragment as displacing and the lateral part staying home. Whereas when we look at this on the AP, it's almost always the medial portion that stays home and the rest of the leg with the lateral side attached to it that displaces proximally and laterally. And not just on the AP either. When we have these posterior medial fragments, it's often the femur that subluxates out the back with these vertical fractures that are often a result of shear. Our partner Dave Beret looked at the frequency and the morphology of these posterior medial fragments and found that in these bicondylar injuries that 45% had a fracture in the medial articular surface. The rest had their exit on the medial side out through the metaphysis as opposed to the articular surface itself. And of the 57, almost 75, 3/4 of them had a posterior medial fragment as opposed to that entire medial piece. And this took up a large portion of the medial articular surface, and the fracture itself was quite vertical. In a similar study, Tom Higgins at Utah found almost the exact same thing a year later. So there we are looking at the posterior medial fragment itself. And now when we see what the problems with these, we looked again from your group, Dr. Krettek, they found that maybe there are some issues with these locked lateral plates. Very stringent level for malreduction was only 2 millimeters, okay? So there's not a lot displaced, but there were 4 infections. 9 had substantial loss of infection, mostly loss of that posterior medial fragment. So maybe we're seeing that these locked lateral plates aren't able to hold that fragment itself. And my partner, Dave Beret, here looked at this and found that, well, these plates in their earliest form had fixed angles of where the screws went. And if you put this on in the advised position, essentially straight lateral, just anterior to that, it didn't really allow for much fixation in this typical fragment that you see here in the back. You can see we're not getting a lot of fixation there. Now other biomechanical studies are starting to show that if you compared dual plating versus locked lateral plating, they were all starting to find that there was significantly more displacement on the medial side when you used these locked lateral plates. There were 2 other studies, one in JOT in 2004, where we looked at the worst of the worst. 83 of these bicondylars, 11 open, 12 had compartment syndrome, and yet this infection rate was only 8.4%. You remember when we were talking about the infection rate with that anterior incision, okay, single anterior incision where everything was peeled back well into the 30%. Now we're down into the single digits for these worst of the worst injuries. And this is a result of that stage management with external fixation, delayed fixation, a better understanding of the fracture, okay, and this dual plating, okay, with 2 approaches as opposed to that one peel away anterior approach, an anterior lateral approach and a posterior medial approach now. He also looked a couple years later at how these did and what mattered. And in fact, the reduction actually mattered, okay? It hasn't been shown as much as we'd like to state, but the MFA showed that the patients did better when there was less than 2 millimeters of articular step up. Having that and using the dual plating as opposed to the locked lateral plating may be advantageous, and you can do it with reasonable rates of infection. So what are the best arguments for dual plating? What are the best examples? Well, it's probably a bicondylar tibial plateau with a significant medial articular injury. If you got to reduce the articular surface anyway and you're looking at it and you've already made your approach, well, you should stabilize it, right? Okay, the next is bicondylar with a significant medial condylar displacement. This, you might be able to reduce that, but I think you're probably going to need to do that open, and you don't need, once you're there, you should do the stabilization right there, likely with an anti-glide or a buttress plate. And then finally, the fracture that's is a bicondylar, but it's more dominantly a medial fracture that also has a lateral articular impaction injury from the die punch of the distal from the lateral distal femur, which came down. So we're going to have to do our medial approach to restore this column, and then we're going to go into the lateral side to restore our lateral articular surface. What would be examples of where you might want to do this locked single lateral plate? Well, if you had a really large large medial fragment rather than that smaller posterior medial fragment where you might get substantial fixation on that part, that might be a more reasonable answer. If it's non-displaced, okay, or easily reducible, maybe that's okay. If the patient has extremely poor local soft tissues and that might preclude or not favor a second approach posterior medial, that might be another example. If you get a poor host who's at risk, brittle diabetic, for example, patient who already has arthrosis and you don't want to have them, if they were to get a deep infection, they may never be a candidate for total knee arthroplasty, or somebody who's already a total knee arthroplasty candidate who you'd be with some of these other issues like poor host or poor soft tissue that you don't want to preclude their ability to get that down the line. Well, there was one study that looked at the fracture pattern and the fixation type related to the loss of fixation just last year in injury, and they found that the reduction, the loss reduction was worse and more likely when you had that small posterior medial fracture than you did if you had a nice big large entire medial condyle when you're using a single locked lateral plate. In summary, we should when we're thinking about what we're going to do for these, we should think, can the soft tissues tolerate a second approach? Well, if you've done your delayed fixation, restoring length with external fixation and allowed the soft tissues to recover, many, many times they can. Is the medial fragment large? So is it something that might be able to be stabilized with a locked plate? If not, you probably need a second approach. Can it be reduced without an open approach? Can it be stabilized without an open approach? Sometimes, not so often. And is there a backup plan if you're wrong? Thanks.
This is a typical picture where I come from, New Zealand. This is the Junior All Blacks, and you can see that with this type of violent contact sport, the various forces applied to the knee are often greater than the structural integrity of that knee can support. And due to this unique nature of our country being religiously addicted to the sport, I got to see a large number of this type of knee ligament injury. The goals of this talk are to reinforce the important clinical examination points. I think we get away from clinical examination sometimes and it doesn't answer all your questions, but nothing replaces an accurate examination in an ideal patient to alert you to the problems that lie beneath the skin. I want to discuss some of the values and features of MRI imaging, and certainly in multi-ligamentous injuries around the knee, the MRI scan gives you very useful and valuable information, and I'll show you some scientific evidence for that. And I also want to highlight the value of early surgery. The problem with these patients is they fall between two camps. They come in under the trauma service, who are often more focused on the bony skeletal injuries. So they get referred to the sports medicine doctors who like to see these patients at 6 to 8 weeks and treat them arthroscopically. And I think the ideal time to deal with these patients is the window between those two groups of clinicians. So they fall between the cracks very often. And I don't know that that ends up giving you the best result, certainly in my experience. The trouble with clinical examination in these patients is that it can often be a difficult thing to assess them. They will have multiple injuries. They could be in the intensive care. They may have a head injury, can even have some spasticity associated with that. They may be transferred to your hospital with an external fixator. And there is a group of them that is extremely large, so they can be difficult to examine clinically. So what are the significant findings on examination? And these are the things that if you're examining a knee that comes in, because often after their injury, you get an x-ray and they look reduced. Anyone who has instability in true extension or any degree of hyperextension greater than their other knee, assuming it's not injured, is a patient you should be alerted to as having a major significant ligamentous injury to the knee that needs reasonably urgent assessment, if not treatment. Increased sagittal plane flexion, particularly where you can sublux the tibial plateau beyond the femoral condyles, is a sign of significant ligamentous damage, probably needing some form of surgical attention. So this isn't the minor posterior draw sign that you get with isolated posterior cruciate ligament instability. This is marked sagittal instability, and I'll show you some examples of that. Never forget to examine the pulses, and I'll give you some statistics on that. And always examine distal motor function, because it's surprising how often vascular and neurological injuries are missed. So this is the typical patient who has a laterally based posterior instability. You can see they have a degree of hyperextension, and then with varus testing there's instability and extension. The patient in flexion has reasonably significant sagittal instability, and that's the type of instability that I'm talking about. They also have instability and extension. So on clinical examination, you can determine that this patient has anterior cruciate ligament, posterior cruciate ligament, and lateral collateral with posterolateral corner damage. So obviously, if you just saw the patient and their x-rays, you may not appreciate the extent of their injury. So this is a patient again. If you look, the patient has relatively subtle hyperextension, but it's there. And in full extension, they have reasonably significant valgus instability. So this is more than your standard medial collateral ligament injury. They have some degree of sagittal instability, but I wouldn't call that gross. An obvious sagittal instability and extension. So that patient has an ACL, PCL, MCL injury, but the PCL injury, looking at that clinical examination, is not something that necessarily needs surgical attention. But if you don't address their instability early, think they have an anterior cruciate ligament problem and deal with that, they will be left with ongoing and crippling medial instability. So clinical examination in these patients, if you can achieve it, is very important. MRI, however, is an essential way of identifying exactly what structures and where these structures have been injured. And for certain injuries such as patellar tendon avulsion as part of their knee ligamentous injury is often the only way you can identify that that injury has occurred. MRI can be delayed till after vascular repair, and if you've got an external fixator on, it's good to think about having an MRI compatible external fixator, which seems to be a slow process in terms of standard of care. So this was a study I did in association with Jens Chapman and one of the registrar residents in New Zealand, looking at the accuracy of clinical examination in these patients. And this is the uncertain or incorrectly diagnosed site of injury. And you can see with things like the lateral collateral ligament and the posterolateral corner, the degree of uncertainty and inaccuracy in this patient due to all their other problems is high. Whereas if you look at MRI scanning, it has a very strong accuracy and positive predictive value. So although clinical examination is useful in alerting you to the patients that need further investigation and treatment, the MRI scan is the accurate way of assessing what has been injured and where it has been injured. If we look at the nerve injuries, 14% of them had common peroneal nerve palsies at presentation, and of these 100% have had ACL, PCL, LCL injuries. So if they have a common peroneal nerve palsy, then they're almost certainly guaranteed to have this complex of injuries. And 30% of these peroneal nerve palsies were missed on initial examination. And often that's because they weren't actually properly examined by anyone. Their knee injury is caught up with a whole milieu of other problems, and this particular problem was unrecognised. They were placed in a cast or a splint or a frame, and not until examined further down the line was that injury identified. And if the cast comes off at 6 to 8 weeks in these patients, and then the peroneal nerve palsy is identified, it's a very difficult problem to treat. Similarly, with the vascular injury, there was a certain percentage of these patients where the injury was unrecognised, and we use the ankle arm index as our standard investigation, and if it's less than 0.9, they then get some form of vascular study. There may be an increasing role of including angiography in your MRI scan imaging as these imaging studies advance. The other interesting thing in looking at these patients in terms of when you manage them was the number of avulsion injuries that could be treated surgically as opposed to a reconstruction. ACL, this isn't an accurate number because if it was a proximal avulsion off the femur, then we went with a reconstruction anyway rather than trying to reattach it, because the recorded outcome of surgical reattachment of the anterior cruciate ligament is poor, and that's been proven in some studies from Scandinavia early on in their treatment. In this initial group of patients, 59% of the PCL injuries were reattachable. When I looked at the first 200, this number had dropped to about 45%. So I think probably people got better at recognising these injuries, and the mid-substance posterior cruciate ligament increased in frequency in my series as I gathered these patients. And also on the lateral side, it's important to see the significant number of these injuries that are avulsion injuries. And if you operate on these patients early, the anatomy is relatively clear. If you operate on them at 6 weeks, it's a completely different surgical field. And so your ability to adequately deal with the avulsion injuries is poor. And so there's been some evidence in the literature suggesting these lateral injuries need an associated reconstruction of some form. But that's in patients that are operated on after 4 weeks, which I think, in my experience, is a completely different clinical and surgical scenario. So I just want to deal with some of the things that you see and begin to recognise. So this is what I call a PCL lesion in continuity, where it's reported as showing some damage to the PCL. So what you see is this overlying fatty coat on the posterior cruciate ligament, and this is the thing that's been injured. And the underlying ligament itself isn't as severely injured, and in fact, when you clinically examine this patient, they have good stability, grade 1 instability, and 90 degrees of flexion. And what happens is this fatty overlying tissue confers some ability for the posterior cruciate ligament to heal. So if you have, but on MRI scan, you get all this shadowing around the PCL, which is where this fatty envelope has been injured. And this is a patient that doesn't necessarily need a reconstruction. This is an irreparable posterior cruciate ligament injury, and you can see it's clearly disrupted at mid-substance. You can't see any continuity of the ligament, and this is irreparable. The interesting thing with these lesions, often the fatty envelope over the top of them will be in continuity. And so what you need to do is remove this fatty layer to clearly identify the extent of the injury. So what you see from this video is this fatty layer over the PCL, but once you get your shaver in and remove this fatty layer, there is just nothing left. It's a gross mid-substance disruption. And then finally you get this group that are actually repairable, which, as I said, in my experience is 40% or so at least, where this large footprint has been peeled off the femur. So it's not a bony lesion. You don't see a bony flake associated with it. It's a periosteal avulsion. And often this can be flipped out the back. And if you don't identify it, you can't retrieve it and repair it early. So what you see is you take away the fatty envelope, and some of the posterior cruciate ligament is visible. It's seen to be in continuity. And the rest has fallen back as the tibia falls back. But I'll show you in some subsequent slides, if you reduce the tibia, then this tissue here can be reopposed to the footprint of the posterior cruciate ligament. So this is a video where you can see this lesion looks to be removed, but as you bring the tibia forward, you can reoppose that tissue to where it belongs. And this is my technique for avulsion repair. It involves a medial arthrotomy with an excision of a wedge of the fat pad, and you get this window into the knee. As we've seen from Christian's talk, the The patellar tendon and the tubercle are a laterally based structure, so you almost, by going paramedial, end up in the middle of the knee. Then you can put some whip sutures in the posterior cruciate ligament stump, and once you've got one in, you can pull it forward and put a more robust suture. So you have 2 whip sutures in that posterior cruciate ligament. And then using the lateral, a small lateral incision, you can drill 2 wires, guide wires, into the footprint of the posterior cruciate ligament. You can advance them until the eye of the guide wire is visible in the knee, and then you can run these 2 whip sutures you have in the posterior cruciate ligament into the stump, and you pull these sutures out on the medial side. So here they are, pulling the posterior cruciate ligament onto the medial side, and you make a small incision just under vastus medialis and tie one suture to the other. And this allows you to pull this posterior cruciate ligament back up to the footprint. And because it has this kind of fatty covering, the potential for the posterior cruciate ligament. So this is the appearance of the posterior cruciate ligament. So if we can run this video, I'll remind you of how it looked before, where we were trying to pull this stump of tissue towards the femoral insertion. And you think, well, maybe. And then if we show how it looks after repair, so this is having gone back in, having repaired the capsule, you can see this tissue coming back into the femoral insertion. And you think, oh, well, maybe that's made a difference, maybe it hasn't. But it's more impressive to look at it. This is through a posteromedial window. So this is the posterior aspect of the medial femoral condyle. The tibia is dropped back, and this is the material of the posterior cruciate ligament. So if we can run this video, please. So this is prior to repair, and you can see that this tissue is well displaced posteriorly. It's lax. It has no real stability, and the tibia itself is actually subluxed posteriorly. So this is the posterior medial femoral condyle. This is after reattachment of the posterior cruciate ligament, and you see the tibia clearly back, restored to where it belongs, and a much more robust structure. So this is the posterior cruciate ligament, once again restored, running into the intercondylar notch. So you can also at arthroscopy get an assessment. This is the popliteus tendon where it's been peeled off the femoral condyle, and you get an appreciation once you develop this injury that it's a whole sleeve of tissue that can be repaired back onto the footprint where it came from, as long as you address these problems early. The trouble with arthroscopy is, if we can run this video, is you get what I call a colander phenomenon. Then when you try and do an open repair of these structures after labouring away for a period of time arthroscopically, you get quite a large extravasation of fluid. And in the worst scenario, this can track into the posterior compartment of the leg and give you a compartment syndrome. You see, I don't usually use a tourniquet in these patients. And what you get is this eventual, that's all the fluid coming out from the arthroscopy. And so it engorges your surgical fluid and can make it difficult. So you always have to be cognizant of how much fluid is going into the soft tissues. So this is my surgical technique for posterior cruciate ligament reconstruction, and you can do this arthroscopically or open. This patient's had the central third of their patellar tendon harvested for the anterior cruciate component, and they end up with multiple guide wires. I like to do the posterior cruciate ligament first, and the technique is to insert it into the femur, and then you can either use the central part where the patellar tendons be taken if you're doing it open, or pass it back through a large lateral portal and bring it back through the knee and out the tibial tunnel. Now, if you look at the collateral ligament injuries, they're often avulsion injuries, and you can see this is a proximal medial collateral ligament avulsion. This is a distal medial ligament injury, so the MRI scan gives you a window into how to reattach these, and this is a typical proximal injury where the capsule's been avulsed, the deep and superficial ligaments have been avulsed, and the semimembranosus has been detached. And you can repair all those relatively easily. So here's our capsular repair. Here's our collateral ligament reattachment and our semimembranosus repair, and you get a restoration of relative normal anatomy. Same with this distal avulsion, you see it peeled off the tibia here. Again, you can reattach these soft tissues and restore what looks something like normal anatomy. You're going to deal with posterolateral and lateral injuries, but again, here's the popliteus and fibular collateral ligament peeled off the femur, whereas here's an obvious more distal injury where you get the whole meniscus avulsed off the tibia and the fat is sucked into the knee as it reduces. And again, this becomes relatively clear when you operate on it early. Here's the popliteus tendon and lateral collateral ligament peeled back. This is distal, this is proximal. This is the footprint where it's all come from. And so you can then repair the popliteus and lateral collateral ligament. Here's the capsular avulsion that often goes with it. So then you put the capsule back where it came from in this kind of horseshoe fashion. You repair the avulsed iliotibial band and you have a relatively normal looking anatomy of the knee. Trying to do this at 6 weeks is impossible. It's just a scar tissue mass. Here's an avulsion distally, and if you peel these structures back, you can see how this whole layer has been avulsed off the tibia and the proximal fibula. And so by getting in there early, you can repair these structures back down and again get a relatively normal looking lateral anatomy. So the poor prognostic signs in these patients for me, delay in presentation. If you have a PCL and collateral ligament injury, they're very difficult to manage late. If you're too big to fit in the MRI scanner, that's a poor prognostic sign. The forces on your repair are great. Those with an associated head injury and spasticity, they'll beat you every time. So in addition to their surgical stabilisation, I often treat them with an external fixator to hold the leg for 6 weeks. So this is a group of patients, along with the large patients, that I actually splint with an external fixator after the surgery. In terms of my results, these are, if you have an ACL reconstruction, a collateral ligament repair, and your PCL is intact, those patients probably do the best in my hands. The bicruciate reconstructions, interesting, or bicruciate surgery with collateral injury do better than the PCL with collateral injury. That's been my experience, and I think it has to do with the correction of hyperextension more than anything. I think I can do that better with a bicruciate operation. The PCL reattachments have had a similar outcome to me as PCL reconstructions, so it's reinforced to me that if I can operate on those patients early, it's a good operation. And collateral ligament reattachments are more stable than having to repair a mid-substance injury. So if I get the rare situation of a mid-substance collateral injury, I usually do an augmentation with another graft as well. So those are the things I've learned, and hopefully you won't have to learn those lessons from experience. Thank you.